871 in Medic 6, you're seeing a 74-year-old male, shortness of breath.
EMS providers periodically come into contact with individuals exhibiting bizarre behavior. This behavior is often a result of alcohol intoxication, the influence of drugs, mental illness, uncontrolled anger, or any combination of these.
I'm not resisting. I want to.
In some cases, however, bizarre behavior may be associated with the serious medical condition called excited delirium. This is sometimes fatal.
Well, excited delirium is a condition that we've recently learned more about. Primarily, we learned about it because of the rise or the prevalence of death in custody subjects. What we used to be concerned about with subjects that were either being hogtied or put into police officers' vehicles, either prone or hogtied. But then later, over time, we started seeing more of them getting tased and subsequently dying. And people were thinking, oh, it's the taser, or it was them being hogtied. Well, actually, as we began to study these subjects, we found that it was neither. It wasn't being hogtied and it wasn't being tased. That we actually began to study the toxicology and the pathophysiology of these subjects, and we found out that these people were suffering a condition called excited delirium, that they were often high on crack cocaine or methamphetamines, and that they also had an underlying cardiac conditions, severe hyperthermia, severe hypertension, and so they were cardiac arrests waiting to happen. And so what happens is they're now in a position, because of the extreme struggle that ensues with law enforcement, and it's just coincidence that the taser or the hog tying that we had previously attributed to their death was just coincidental because it was occurring at the same time.
Can I help you?
The term excited delirium was first used to describe the acute behavioral changes associated with the abuse of stimulant drugs like methamphetamine, PCP, and cocaine. It has become more widely used to describe any individual who is demonstrating a specific group of physical signs.
I don't know. It looks like he's on something. Possible.
Associated behaviors in excited delirium patients include agitation, grossly psychotic behavior, exhibiting feats of extraordinary strength and endurance, especially during attempts to restrain. Patients often seem insensitive to pain. Their ability to focus, sustain, or shift attention is impaired, and they are easily distracted. Speech is loud, rambling, and incoherent, and it may be difficult or impossible to engage the person in conversation. The patient may be disoriented in regards to time, location, and purpose. They may misinterpret perceptions of events in their environment. They may become delusional or experience hallucinations. And due to an elevated body temperature, many patients will remove clothing while still sweating profusely. Patients often exhibit violence towards shiny objects like mirrors and glass.
They're exhibiting animalistic behavior because their intoxication and their delirium puts them in a total animalistic level of activity. And that's why they're completely unable to reason.
Delirium can be caused by several factors, including substance abuse of or withdrawal from stimulants, adverse reactions to or withdrawal from therapeutic drugs, as well as physical or mental illness. It's not easy to identify signs of behavior that are consistent with excited delirium, but they are very different than the often slowed, dulled, and inappropriate behavior of simple alcohol intoxication. Sometimes other conditions do mimic excited delirium, including drug and alcohol intoxication or withdrawal, low blood sugar, overactive thyroid, pure psychiatric disease, dementia, sepsis, and head injury. So it can be challenging to differentiate excited delirium from other causes of abnormal behavior. But there are classic calls that should give you a good indication.
You'll get a call that, from a hysterical mom. She came home, she found her kid just, he's paranoid, he's naked, walking around the room thinking he's going to die. He's very paranoid. They have a fixation about glass. Often you'll get a call for someone going through a neighborhood, breaking out windows with a baseball bat, and you'll think, oh, this is just, hooligans and, kids just, gangs and stuff. But you get there and the guy is naked. It's February, which is kind of an unusual call in St. Paul for a guy to be naked in February. But that's generally a good key, because the reason why these people are naked is because they're hot. They're already hyperthermic, and so they begin to strip, and so that's a key classic call.
If the situation is unknown and you arrive at the scene first and recognize signs of excited delirium, call for police and additional resources. It's important that law enforcement and EMS work together in an effective and coordinated way when dealing with a patient who may be suffering from excited delirium. Together, they can identify patients who are possibly in a state of excited delirium and manage the situation in a manner that minimizes the risk to all those involved.
All right, these guys are really cool guys. We're all going to help. We're getting them out. We're going to get them out. Talking in the lights.
They're not just simply intoxicated. They're not just simply wigged out. They're not just simply high on drugs. They're not just simply having a bad trip. This is an acute, life-threatening medical condition. They're not necessarily committing a crime, and that's the issue. And so EMS often gets confused when they get into these situations going, well, is this a crime? We're EMS, we're not law enforcement. It's not our job to decide whether a crime is in progress. In fact, it's not even law enforcement's job to decide whether a crime is in progress. Their job is to protect public safety.
First responders typically take a hands-off approach when called for a violent patient, since they lack the training and tools to deal with these situations. However, sometimes you need to restrain and control a patient so treatment can begin, or because they become combative.
Why do you call these guys? Seriously, I don't need this. What are you doing?
You guys gonna put some seatbelts on, yeah?
No.
Seatbelts.
If a patient you are already caring for becomes agitated and violent, you'll need to take steps to ensure the safety of you and your crew. Retreating from a patient who needs medical care is sometimes not an option. Several studies have confirmed that excited delirium is an imminently life-threatening medical emergency, and that the patient is already suffering severe medical problems before responders arrive on scene. They require immediate medical interventions.
EMS needs to be prepared to have enough resources to adequately restrain the subject, then rapidly begin cooling the subject, looking for other medical causes such as hypoglycemia, hypoxia, rule out the other type of medical causes other than acute intoxication with methamphetamines. I mean, maybe this patient has a head injury. Maybe they're hypoglycemic. Maybe this is some other psychiatric condition. For ALS providers, then the idea is having at your disposal the use of pharmacologic agents to sedate these patients.
Violent behaviors and actions of an agitated state lead to a physiological response from the body, especially when trying to restrain the patient.
The most important thing is to minimize the amount of struggle. So for BLS, that's in the absence of having the pharmacology, BLS's role is going to be to minimize the amount of struggle, to then fight hyperthermia by the application of cool packs, spraying the patient down using fans, passive cooling techniques. If they have access then to ALS with ALS intercepts, then establishing IV fluids and volume resuscitating the patient, because we know that besides being hyperthermic, they're also acidotic, and that means that their potassium levels are elevated. And so we volume resuscitate them to try to drive their potassium levels down.
A physical struggle causes the body to release catecholamines. As they enter the bloodstream, the body pumps the heart faster and creates an increased demand for oxygen. The lack of oxygen causes the arteries to the heart to constrict, shutting down the blood flow and affecting heart function. After struggles cease, in some reported cases, a labored or shallow breathing pattern is noted, and then patients suffer cardiac arrest and die.
Unless this subject is a clear and present danger to himself or the public, let's just step back and take a moment, contain the subject, and let's just get prepared so that when it's time to restrain him, we're ready. And because what we know from our studies is that if these subjects go into cardiac arrest, we cannot resuscitate them. Unlike regular cardiac arrest, that if they suffer cardiac arrest in front of us, we start CPR, we can almost always get them back. These type of cardiac arrests, if they arrest, 100% lethality. They all die because they are so acidotic, they are so hyperthermic, their potassium levels are so high that once they arrest, they all die. And so the key for our success in EMS is to prevent the arrest. And so the only way to do that is to pre-plan your attack and coordinate with law enforcement.
Under some conditions, it may be necessary to forcibly subdue a person, even one suspected of suffering from excited delirium. Police will often use tasers to gain control. In some cases, tasering has been blamed for excited delirium deaths, but scientific evidence to date is unclear. Considerable attention has also been paid to restraint use when controlling these patients. Again, there is no valid evidence that the way these subjects were restrained caused death by positional asphyxia. However, placing a patient in a prone position can interfere with diaphragm movement, so it is not recommended. EMS and police should work together to determine the best way to restrain or subdue a patient.
These subjects are often going to be placed into protective custody, and the whole concept of whether, even if the patient isn't agitated delirium, of patient restraint is one of medical legal concern for both law enforcement as well as EMS. And so this is a prime opportunity for both law enforcement and EMS to come together and deal with an issue that is important for both of them and is important for the safety of the patient, and to develop a set of guidelines and protocols and train together so that they both have an understanding of what each other's role is, so that in that critical time they're not fumbling over each other and they're good partners.
Almost all in-custody deaths result in some type of litigation and usually focus on the method of control. Positional and compressional asphyxia are terms frequently heard in courtrooms. Methods of restraint become issues of contention in a lawsuit and may be the turning point in the liability of an agency. Follow your local protocols for restraint procedures and consult your medical director for treatment of behavioral emergencies.
The problem has been, the concern that's caused the death in custodies is that law enforcement has failed to recognize that these subjects are unable to comply. And so when you watch the videos where there are deaths in custody and there is repeated use of the taser and then prolonged struggles, you'll hear them saying, comply, 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 quit resisting, quit resisting, quit resisting. And yet the guy's fighting like an animal. And everyone's, well, there's no surprise. And it's like, well, you know, you can say, well, this is an animal. And so I'm not sure that it's inappropriate to not treat them like an animal. And you get onto them and you sedate them. And it's very much like you would do with a DNR coming in. There's a bobcat in your backyard, and you contain them, you tranquilize them, and as soon as they're contained and tranquilized, then you transport them. Because you can't reason with them. You can't make that human connection with them. And so I don't know if that dehumanizes them. I think that actually probably expedites better care for them if you try to do that.
Once a patient is restrained or controlled, Responders must maintain a constant vigilance of the patient's condition. A previously combative patient who becomes suddenly quiet should raise a red flag. Many reports of in-custody deaths attributed to excited delirium describe sudden calmness just prior to death.
And of course, once you have sufficient manpower on the subject, then you let off of the taser, and that's then when EMS comes in, administers the medication, and then it's a matter of just simply a light restraint. Give the medication an opportunity to take its effect. And with a lot of these medications, and one that we've been using at Health East in St. Paul is called Geodon, which is one of the atypical antipsychotics. And we have had phenomenal success with the administration of 10 to 20 milligrams of Geodon intramuscularly. Within 10 to 15 minutes, these subjects are very compliant. Sometimes we'll have to add a little supplemental Ativan, but usually they're very compliant, and within 10 to 15 minutes we can establish an IV and begin to hydrate them up and treat their hyperthermia and transport them to the psychiatric unit.
EMS care includes assessing the ABCs and applying oxygen. Obtain the patient's temperature soon as possible. These patients often have temperatures between 102 to 108 degrees. If hyperthermia is indicated, cool by misting and fanning or by applying ice packs in the groin and armpits. Apply a cardiac monitor and pulse oximeter. The initial decompensation in these patients appears to be respiratory arrest rather than cardiac arrest. Aggressive airway management and advanced cardiac life support protocols at the onset of these symptoms might be life-saving. It's important to stabilize the underlying psychological and physiological problems as soon as possible. If the patient remains combative, consider the use of sedatives in accordance with your protocols. Consider the use of Versed via the needleless mucosal atomizer device. This allows for drug delivery with minimal risk of accidental needle stick to responders. Once the patient is calm and accessible, a blood glucose level check should be performed and an IV of 60 degrees Fahrenheit normal saline is initiated and infused wide open. Monitor the patient's breathing at all times. Adjust their position to maximize their ability to breathe. Alert the hospital to stand by for an agitated patient. Soft restraints to control the hands, limbs, and chest might be used in the ambulance during transport. Leather restraints are recommended when available. As always, follow your local protocols. There are advantages for all emergency responders in having a coordinated strategy when called to deal with a violent patient. Recognizing the signs and symptoms of excited delirium and having an increased awareness that these patients are at high risk for sudden death will help you take quick and decisive actions. Excited delirium is not just a behavioral emergency, it is a medical crisis that requires immediate medical interventions.